Okay, thank you for joining us today, everyone, for our webinar. Just a couple quick things before we get started. You can submit your questions via the questions panel throughout the webinar, and we'll try to get to those at the end. And your certificates will be available this Friday if you indicated you would like one by logging into your account. There aren't any handouts for this presentation because we have unpublished research being discussed today. And Donna, if you would like to get started, go right ahead.
Okay, thank you, Kim. Thank you for bringing me here today to talk to you all and present some exciting research that myself and my team have been pursuing, particularly in the clinical realm. So what we're going to talk today about is the role of antenatal screening and postnatal point of care testing with the aim of maximising milk production and extending lactation. I must acknowledge the people that I work with. They're fantastic. Dr. Stuart Prosser is GP obstetrician and anaesthetist and is driving this through his clinical practice along with Dr. Sharon Perella, who's a neonatal nurse, PhD, and an IBCLC. And this is my gorgeous group here. They're very good looking because they live in Australia, and these are the people that are involved in the data that I'm talking about today. So as we move on, we need to look at why we are doing this work, and what we've been doing so far over the past 50 years hasn't really impacted worldwide breastfeeding rates. We can see here that initiation within 1 hour of birth is still under 50% globally, and we only have 44% of women exclusively breastfeeding to the WHO's 6 months, and that's even lower in Australia. And continued breastfeeding for 12 to 23 months is only sitting around 2/3 of mothers. And for many, many, many years, the same reasons for early weaning have been cited by mothers. And that's that infants are not satisfied by the breast milk alone. In other words, they have a perception of low milk supply. And even in our studies at the Breastfeeding Centre in Western Australia, we found that 44% of mothers attend this clinic because they perceive that they have low milk production. So I want to discuss our results today within this assessment framework of lactation that we've worked up. And so we're talking about the period from conception to about 6 weeks postpartum. And that's because the critical window to establish milk production is the first 2 weeks. And at 2 weeks, milk production predicts production at 6 weeks, according to the evidence. So we're going to talk about antenatal screening, which in our model of care occurs around about mid-pregnancy, and then the need for postnatal screening as well. And then we'll talk about our exciting results around point of care testing in the clinic, and also through this whole presentation, pregnancy complications, which are increasing in incidence, and how they relate to milk production will also be discussed. And finally, I'll tell you about an RCT that we're performing down in Perth, and we're about 1/3 of the way through. So let's start with the antenatal screening. If you look at the evidence in the literature, both human and animal models, you can see that there are known risk factors for suboptimal lactation. And most common are these metabolic dysfunctional states that women are increasingly in when they're pregnant and lactating. And that's diabetes, polycystic ovarian syndrome, thyroid issues, for example, and infertility. Then we have anatomical factors such as breast development, nipple surgery, breast surgery, and all of the things to do with the actual anatomy and development. And then we have psychosocial, the realm of that, where we know that short intended duration impacts breastfeeding and lack of support. We often perceive breastfeeding as largely ignored until after the birth. So obstetric care is typically limited to the waist down, and breastfeeding intention is recorded. We found in our most recent caesarean section study, where we investigated the experiences of women after caesarean section, of 1,200 women, about only 20% attended breastfeeding antenatal education. So this is our tick box screening tool that we have developed with clinicians and researchers. So first of all, we ask about breastfeeding duration and previous difficulties. Then we tackle the breastfeeding, the breast anatomy, so any history of surgery, nipple piercing, no growth in pregnancy, and you'll see that that is a huge red flag, and maternal concerns re nipple size and other things like that. So we also look at the metabolic health of the mother. So we ask for pre-pregnancy BMI, pre-existing or gestational diabetes, PCOS, thyroid disease, and any pituitary disease. And then, of course, we have mental health concerns because we know those are associated with shorter durations of breastfeeding. So this was designed based on published literature, and it was implemented into Stuart Pross's practice in 2019. It's completed routinely face-to-face with a midwife at the 24 or 22, 28-week appointment. So let's quickly run through why these conditions actually have the potential to impact breastfeeding and milk production. Well, if we look at the anatomy, this is a schematic that still exists today that shows lactiferous sinuses, and they're reported to hold large amounts of milk. We have this absence of glandular tissue behind the areola and the nipple, and we have the branching here into the lobules and the alveoli. And this was based on Sir Astley Cooper's work, this beautiful dissections made of women that died in lactation, and you can see that these have been expanded, these ductal structures, with hot glue or wax, and then meticulously dissected and lain over a stone there. But what we found in our anatomy studies was that wasn't the case. There were an average of 9 ducts, and they were very small. There's a lot of glandular tissue sitting below the nipple and within the 30mm diameter of the nipple, and most of the ducts branched within the radius of the areola, and they're superficial and they're easily compressed. And you can see here that the nipple up here and the collecting main milk duct here is the same diameter as one of the branches. And you can see it branches very quickly and it's very close to the skin. So as I mentioned, most of the tissue that's situated under the areola and within that 30mm radius is glandular. So we have 2/3 of the tissue under there being glandular and the rest being intraglandular fat or adipose tissue. And so our discoveries led to a new understanding of the breast, where we see much more glandular tissue under here. We have much more branching of the ducts, and we also see them entwined. So it's not unusual to see a lobe track with its collecting duct or main duct towards the nipple and traverse across the breast and enter from a different direction. So what does this mean? What does anatomy, our discoveries of anatomy and changes mean? Well, if we look at surgery in terms of reductions and augmentation, we can go back to the literature and see more dissections that show, by going in particular, that some lactating breasts only have 4 patent ducts. So if you sever one of those ductal openings, you may only have 1 or 2 lobes draining or able to produce milk. And Love and Barsky found 5 to 12 ductal openings, and as we said, I found 9 in my study. So with breast reduction, we have a repositioning of the areola of the nipple, and we can have aggressive removal of the glandular tissue around the breast and under that area that could easily compromise milk production. While large breasts may have a lot of adipose tissue within the glandular tissue or entwined with it, it's difficult to remove surgically. So impaired milk flow due to reduced number and size of ducts could well affect milk production. Implants that are placed into the breast to augment the breast are also potentially problematic during lactation. I told you the ducts are very compressible, so therefore when the breast gets full, it's potentially feasible that these implants may compress the ducts, obstructing flows again. Also, we don't know if there was insufficient glandular tissue prior to the surgery, so we don't know if the mother's breasts were actually hypoplastic. And what does this mean about pathology? So we see more and more pathology as women are getting older and having babies and lactating. In particular, we get reports of mammary hypoplasia. It can be bilateral or unilateral, symmetric or asymmetric, and histologically you see much more fibrous stroma and fewer ductal structures without the differentiation into the alveoli. So they resemble the prepubescent breast. So this lack of lobular development is contributing to lower lower capacity to make milk. It's considered rare, and often in the literature it is stated that it's rare. But as we move through this presentation, we may have to reconsider that. This is an example of a mother who came to us with unilateral hypoplasia. You can see the underdeveloped breast hair, and on ultrasound, the macroanatomy looked normal, but we saw reduced glandular tissue. We also saw reduced blood flow into this breast. Typically during lactation, blood flow to the breast doubles. So this is another sign that development hasn't happened normally during lactation, during pregnancy. And this mother could only get 6 mils maximum out of this breast. We're also starting to see occasionally cysts that would normally resolve during lactation and pregnancy to persist during lactation. So they could be an added problem with compression on the ducts and obstructing flow. And of course, fibroadenomas here, which are the solid benign lumps of the breast, can also have similar problems. In fact, in some mothers, we've seen multiple cysts, and particularly under the areola, where it's difficult for the baby to latch. We've also looked at nipple piercings, and in general, the internet states that in general, piercings of the nipple will not affect your milk supply or your ability to make milk. That may well be true, but if you cannot remove that milk, apoptosis will occur and milk production will downregulate. Here we have a case, we published some case studies of women with nipple piercings that had come to us, and this is a mother's left nipple, and you can see very small ducts coming up here towards the tip of the nipple. And on her right side, where she was unable to get any milk out, we saw very dilated ducts with septa in them. So these ducts were obstructed and she was unable to remove the milk from the breast. We typically see, as I said, greater blood flow. So on the right, we saw good blood. On the left, we saw, I think I've got those a little bit mixed up, so that's right. So this on the left is the good side. So you can see this very nice flow, large arteries here, lots of flow, and 251 litres is coursing through that breast in 24 hours. We have a milk production of almost 500 mils, which is great. But on the other side, we have a milk flow of only 8 mils coming, 7 litres going through the breast, and we have only a milk production of 8 mils. What about metabolic issues? Well, metabolic issues often affect gene expression. What do we know about gene regulation of the mammary gland in women during lactation? We know very little compared to dairy cows. And in fact, you can see here a list of some of the things we do know. The hormones that we know are involved in lactation and development. And we also know some of the actual gene regulation. So as I said, the gene regulation is important because it helps switch on secretory differentiation, that development of the breast and proliferation, and also activation as well. So with each pregnancy, there's methylation of these genes that makes switching on much more quick, much more rapid in subsequent lactations. As I said, some of the hormones that are involved in the development of the breast are also involved in things like diabetes and insulin resistance and thyroid dysfunction. And if we have a quick look at that, then one of the main pathways or family of genes involved in mammary gland remodeling is the STAT family. So you can see here that STAT6 is all about developing the breast and the alveoli. And then STAT5 is all about lobular development and expression of milk proteins, which is part of milk production. And STAT3 is involved in involution. We know from animal models, of course, that prolactin, this complex pathway that's by no means complete, is important for lactation, but so is insulin and the insulin receptor. And you can see here in these mice without receptors, they're the mothers without receptors, the pups, are much, much smaller, suggesting there's a reduction in milk synthesis. Also, other genetic variants are being seen now, both in women and animal models, and zinc transporter mutations, zinc transporter 2 and 4 are implicated in the production of milk being reduced, and also disorganised development of the mammary gland, such that the tight junctions don't close and the polarity of the cells are affected, so sodium can leak through. And this is reported to be the incidence in women to be as high as 20%. So why is that important? Because a lot of our strategies in lactation is about removing the milk so that synthesis can keep occurring. It doesn't get down-regulated, it's up-regulated to meet the baby's needs. Polycystic ovarian syndrome is also associated with shorter breastfeeding and higher BMI, and no increase in breast size. So far, we've only got 2 studies that show that metformin and androgens have no effect on breastfeeding duration. But we really do need to have more comprehensive studies to see if these are in fact the mechanisms by which PCOS is impacting breastfeeding. Hypothyroidism as well, we're seeing more and more of that in women, and that can block the thyroid hormones, and the dysfunction can block the prolactin pathway. So that's a mechanism by which milk production can be downregulated. And STAT3 is also involved in this. And remember, I told you that was involved in apoptosis or involution of the gland. So if this is upregulated, then we're going to have more involution than function going on. And it's also associated with low protein expression. As I said, this is intimately related to milk production. So what have we been doing with this screening tool? If you have a screening tool, we really need to inform clinicians about how to use it and what should they do when they have a mother that's identified as being high risk of suboptimal lactation. So Sharon has developed this traffic light system with her clinicians, and that is how we inform women of their risk. So here you can see this here. So anything red is really to strongly encourage the breastfeeding workshops that we hold, which are evidence-based, and one-on-one antenatal lactation consultation in pregnancy. So these mothers have a conversation about the fact that we think there could be a risk after birth that things may not go as well as expected. And that's in the red here. So most of our metabolic diseases, as well as outflow obstructions of the milk, as well as no growth in pregnancy. And then for the orange, the pre-pregnancy BMI and previous difficulties, which may be due, of course, to mismanagement in the previous lactation, we offer a breastfeeding workshop and one-on-one antenatal consultation. So we're really asking the mothers to get themselves educated. Remember, only 20% of our caesarean section mothers had actually attended any antenatal education. And then if there's any concerns re nipple size, again, we offer the breastfeeding workshop. So I'd like to show you some of the results of an audit that was done between January and December. And you can see here that we've audited or followed up for breastfeeding outcomes at hospital discharge, 2 weeks postpartum and 6 to 8 weeks. These were the intentions to breastfeed. So we had 20% of mothers intending to feed less than 6 months or up to 6 months, and then only 45% that we were going to feed from 6 to 12 months, and then those that were going to feed more than 12 months was 21%. This is really interesting here to me. So first of all, in the red, the highest incidence of risk factors was no breast growth in pregnancy. So that's 18%. Rare is considered 1 in 1,500, which is 0.07%. So I would be hesitant to say that this is rare, at least in the contemporary situation we have now. You can see here that breast augmentations around 4%, reductions are less than 2%. We the mothers believe they had surgery due to hypoplasia, 3 of them, and then we have hypoplasia at 5% here. And apologies, but it's hypoplasia that's considered rare, as well as no breast growth in pregnancy. And you can see it's much higher than the 0.07% of being rare. Nipple piercing, again, 8%. So this outstrips our GDM mothers as well as hypoplasia. So we've got a lot of that in our population. 10% for polycystic ovarian disease and about 8% for thyroid disease. And 9 of these mothers were already medicated. So we tended not to see such suboptimal lactation outcomes if it was controlled. So here we have the amount of mothers that have no risk factors, and you can see here that at discharge, over 80% were fully breastfeeding, and we had about 15% mixed feeding. But over time, we did see a decrease in the amount of mothers fully breastfeeding to 6 weeks, with an increase in the mixed feeding. We also, when we look at the breast hypoplasia, you can see only 40% were feeding at discharge, with 40% mixed feeding. This bumped up slightly to 60% at 2 weeks, but dropped again to 6 and 8 weeks. And we can actually see this increase in formula feeding here. This is full formula feeding as opposed to mixed feeding. With the nipple piercing, again, we start very high at discharge, but we see a slope moving downwards, finding that women are stopping fully breastfeeding. We have an increase in mixed feeding, and then at 6 to 8 weeks, introduction of formula. Polycystic ovarian syndrome, we have the same issues here. Less women are fully breastfeeding at discharge, interestingly, and an increase in mixed feeding. So it seems to be around the 6-week mark that we see formula introduced. With our gestational diabetic mothers, however, we have a decrease in full breastfeeding and an increase in mixed feeding, but none of our mothers were feeding formula only, so they hadn't weaned by this stage. No breast growth in pregnancy certainly also saw a reduction in full breastfeeding and an increase in breast milk and formula feeding. Now, I'd like to point out that these are coming through Stuart and Sharon's practice, so they're very well educated and encouraged to frequently empty the breast at least 8 times a day, whether it's breastfeeding or pumping. So 43% of the women had risk factors, and what they found clinically was that implementation was very easy and it became routine. Clinicians really liked it because it raised the opportunity to discuss breastfeeding in pregnancy. It gave them the opportunity to educate and guide women. It also set expectations so that women were prepared for potential problems after birth and were much more satisfied with their experience. It was well accepted by women, and several cases of hypoplasia were identified for the first time. Some of the aspects of this tool have already been implemented in our West Australian Health Department's latest edition of the statewide pregnancy handheld record, meaning that now our community of clinicians and health professionals are recognising this and are keen to disseminate the information. So now if we look postnatally and look at these pregnancy complications in more detail, you can see from this unpublished data that we are preparing for publication, with over 600 milk productions that we have in our data banks, we calculated the risk of low supply for each of these pregnancy complications. So with GDM, we saw a 7 times increase in risk for these women for low supply. Gestational hypertension was 8.8 times higher risk for these women, and a low birth weight baby 12 times more likely to have an increase in risk for milk production. This is retrospective, and so this was really concerning for us because it's a huge increase. We didn't expect to see that, but if you look at the pathways by which these pregnancy complications are affected, for example with diabetes and growth hormone and all sorts of other hormones, it's quite feasible that the link between pregnancy and the placenta is also linked closely to development of the breast and its synthetic capacity. So for postnatal screening, we're looking at very quickly learning in late pregnancy whether there's preeclampsia or increased blood pressure and late GDM. We also must acknowledge that postpartum hemorrhage has always had and been recognised to be associated with decreased breastfeeding here. And this is just when you see more blood loss, you see greater effects on breastfeeding, and we still don't really understand why. So let's move to the exciting part of the presentation, which is point of care testing. So what we've been doing is trying to identify components that reflect breast development and function. So breast development, of course, has critical windows in the fetal window, at puberty, and then, of course, at pregnancy, where the breast develops completely into a functional gland. As I said, we don't know enough about the hormonal control and the genetics surrounding this, and we hope to learn more in the future. But then after birth, we have secretory activation occurring in about 1 to 5 days at the outset, and that physiological changes occur that change the components in the milk. And then we're looking at that 2 weeks, 10 days to 14 days where milk production should be established, because the literature shows that mothers should be making around about 600 to 650 mils of milk by day 8. So it's secretory activation that these processes occur. The tight junctions between the cells here close, so they limit the amount of sodium coming through from the basement of the membrane of the cell here. We also have upregulation of protein synthesis, citrate, and lactose. And of course, lactose also drives volume, milk volume. These biochemical changes occur before the mothers feel it, so within 24 to 48 hours, whereas they may take as long as 48 to 72 hours to feel their milk come in. So when we look at sodium here, you can see this rapid decrease in the first 3 days after birth, and then it plateaus. And that happens for the mothers of preterm infants, the same as term infants. So we see this rapid decrease, which suggests that secretory activation has occurred. We've been validating this little iron selective probe here, where you put a drop of milk on here, shut the lid, and you get a digital readout just like that, fits in a pocket. We've validated that against more robust methods of measuring sodium, which is inductively coupled plasma optical emission spectrometry, which is really quite a mouthful, and it performs very well. So we think that this is good enough, definitely, for clinical practice. And Anita Esqueras has also tested this. She's come to our lab from the US and brought her samples with us, and she's a clinician and a researcher, and in her hands, she was still able to validate this probe. So we've just completed a study in the NICU on pump-dependent mothers, and we looked at 44 women after preterm birth, 27 to 34 weeks gestation, and over half of them, it was their first baby. We got bilateral samples and their 24-hour milk expression volumes, and we tested the sodium with these probes every 2 days from day 2 to 10, and then third daily from days 13 to discharge from the unit. You can see here with this graph that you see a rapid decrease in sodium between day 2 and day 4. And if we use 16 millimolars, which is really the cutoff, above that, we would suggest that secretory activation hasn't occurred. And you can see that there's a lot of this going on. And at 48 hours, when we would expect to see it in term women of term babies, we see a big delay. And then that seems to have been pretty much ameliorated by day 4. But when we look at sodium compared to the volume of milk that the women are producing, this is 500 mils here, so it's commonly called coming to volume. And you can see here that by day 6, only 50% of mothers have reached 500 mils, and by day 16 here, 75% have achieved 500 mils. However, we really need to set these women up to be able to feed their term babies. And so we'll put the mark here at 700 or 650 mils. And you can see that by day 16, which is well past our a few days past our 2 weeks, only 50% of women of preterm infants are able to achieve what we would consider close to a full milk production. When we look at treating this as a potential predictor of low volume or a potential predictor of early intervention and monitoring of these women to see how they're doing, we do these sensitivity and specificity analyses and positive predictive values and negative predictive values. In a nutshell, there is seemingly potential that if we see high sodiums, it's very predictive, sensitive to that when there's low milk supply. And similarly, when we have normal sodiums, it's more likely that they have low milk supply than a normal supply. However, it's not perfect, and we really need to have more study and more women in the study to determine that and actually create those predictive models. So basically, we want to do some more work to contribute to the limited longitudinal data and also to potentially create a reference range. And as I said, we need sample sizes powered for sensitivity and specificity analyses so that we can really validate this as an accurate point of care tool. What we did do as well was we gave Stuart Prosser a sodium probe for his birthday, and they are now using it in the clinic when he's in the clinic to see how you would integrate this into looking at the lactation of women of term babies. So typically you would use quantitative measures potentially to look at milk production or to measure milk production, and infant weight gain changes, of course, are useful only if the baby is exclusively breastfed. Secretory reactivation is really relying on the maternal report of milk coming in, and if it's their first baby, that may be difficult for them to tell us. Enough urine and stool output in the first 4 weeks. Often mothers don't realise how low it is until it increases. 24-hour milk profiles that we perform in our lab and with our clinicians are limited in availability for everyone else at this current stage. And also breast palpation and observation, particularly with mastitis, because this probe will detect high levels of sodium associated with breast health, so inflammation and mastitis, which Sharon also showed in the previous study that I showed you before this. So unreliable measures include signs of milk transfer such as swallowing and nutritive sucking. It's very hard to determine that. Single test weights can be problematic if they're not done in the right conditions, and they're often used in our breastfeeding centre. Well, they're not often used as a single test weigh, they're often used as multiple test weighs during a session with the lactation consultant. Milk colour, pumping volumes, and satiety and breast fullness are often unreliable. The laboratory-based lactation assessments that we have access to in our research lab really aren't, they really are limited to the research setting because they take too long. We can't perform them quickly enough for health professionals to act with mothers, of course. So that includes our ultrasound and suck, swallow, breathe assessments, test weighing, and the biochemistry of the milk and the microbiology in terms of mastitis. So we again have a traffic light system for this point of care testing. So above 16 millimolars, based on the literature, we consider that a red flag to investigate. Between 12 and 16, we should be monitoring and ensuring adequate milk removal. And under 12, reassurance and no action is often considered. So looking at another audit of 40 women at about 2 weeks postpartum, it's a big range here. We had 51 samples, and 50% of mothers had no breastfeeding concerns, so they just did the tests in the waiting room before they saw Stuart. 33% had concerns with low milk supply, so that number keeps popping up, and 17 had breast and nipple pain. Here is the graph. So there's millimolar here, and this is the line for 16 millimolar. So everything below that is usually considered normal. However, we do look closely at the women that sit between 12 and 16 because, as I may have mentioned, that 12 has been used in the literature before as well. So you can see around about 6 women attending the clinic had very high sodiums, and around about 6 women had questionable sodiums. Here's what it looked like. So at 16.3, we felt this mother had delayed secretory activation. 22.9, which is really high. She had low supply, had been exclusively pumping and could only get 100 mils per 24 hours. And then 23.8, low supply and a history of GDM. And then very high here. And we thought the milk might be coming in because it's day 3. So it was decided to just hang off for a day or 2. And then we had an unexplained high sodium. In our orange band here, our orange light, we had a baby that lost 12% of the birth weight, high sodiums, suggesting low production and delay in initiation. And then we had left breast pain. We had a high sodium. This mother wasn't going to tell the clinician she had a bit of a sore breast until she was asked if she'd like to have her milk tested. So we think we may have diverted an episode of mastitis. This mother had already had bilateral mastitis, and her left breast felt okay, and her right breast she felt had reduced supply. So it looks like this hasn't resolved completely. In our below 12 millimolar, we see a lot of different things. We see that the right side has a lower production and slightly higher sodium. We have postpartum hemorrhage here. We have normal sodium suggesting the mum is initiated but has a low supply. And then bilateral nipple piercing, we have initiation happening and potentially normal glandular tissue, but a low supply, perhaps due to milk flow obstruction. So what did the mothers think of this? The mothers love it. They really do thrive on having their success either confirmed or their concerns also addressed. So they felt it was positive and easy. What a few women needed to hand express had a little bit of help. They found it reassuring, as I said. It was good to know everything was going well, and it's tiny and it fits next to the sink in the clinical space. Particularly from Stuart, his comments were very insightful. He said it confirms clinical suspicion of where the patient is at in the breastfeeding cycle and allows either reassurance or appropriate intervention. It's quick and it allows instant feedback. It gives the patient a number and a visual representation of where they are, what they are actually doing, and it allows them to work with the provider to achieve the best result. So as I said, again, in the term mothers, we really need really clean data and measuring of sodium to really determine what the cutoff ranges are. So future work, we need to do repeated frequent sampling on many, many more mothers to establish normal sodium levels in healthy women with good milk supplies. So we think that POC testing, point of care testing of sodium, offers a valuable clinical tool for health professionals in the assessment and monitoring of lactation that can confirm normal lactation, assess secretory activation, investigate low weight gains in supply, and also evaluate breast pain and monitor mastitis and whether management is succeeding. So finally, I'll just leave you with a little tantalising area here, which is our RCT. So when we realised all these women at such high risk of low supply, we put together a bundle of care and we got some funding to carry out this RCT. So it was the aim is to determine whether early and frequent milk removal and phone support across the first 3 postnatal weeks improves 24-hour milk production at 2 and 6 weeks, breastfeeding exclusivity at 2 and 6 weeks, and breastfeeding duration. We're also monitoring physical and emotional well-being of the mothers and incidence of infant infection, and that goes across 12 months. So what we do is we randomise each woman to standard care. The control group is identified, as I explained in the antenatal questionnaire, and encouraged to get support as well as education so that they are somewhat prepared after birth. But in the intervention group, we loan a symphony pump to the mothers in late pregnancy so that she has access to a hospital grade pump should the baby not be feeding well and any of the flags of delayed secretory activation occurs. We have an IBCLC making phone calls every 2 days for a week, for up twice a week for up to 3 weeks after the birth. So they then do all of this sampling for us. So they take milk samples at 1, 2, and 6 weeks. We have feeding data all the way through to 12 months. So they log their feeding data. They do milk productions at 2 to 6 weeks. And we monitor health and wellbeing through surveys. This is the intervention group currently, and you can see there's an even spread of GDM, PCOS, and histories of low supply, and SGA, small gestational age. We have one hypertensive mother in here. We have slightly more women in the control group with risk factors, more than 2 risk factors, or 2 risk factors or more, but we're still early days in our recruitment. So I'd just like to also state that we had a sneaky peek, and this intervention group is confirming all the clinical responses we are having with identifying women and educating them early, and that so far the intervention group has better stress scores than the control groups. They have significantly lower stress, likely due to the expectations and their ability to cope with what's going on. So I'll leave you with that assessment framework for lactation, and then I'd like to probably challenge you to think about what you might do with this information. So looking at the CDC rates here of breastfeeding for the USA, you can see that exclusive breastfeeding is quite low and declines, as does any feeding. So I decided to plot our GDM study. So we have a prospective GDM study where we did exactly what we did in the RCT, which informed the RCT. And we found that almost all of our mothers kept feeding. So whilst any breastfeeding, they were at 90%. So that was a huge success in our opinion. Sorry, this is the nipple shields. I apologise. So our nipple shield study shows very high rates of breastfeeding using shields to maintain their breastfeeding experience. And then, as I said, with the GDM, our mothers are over 80% of them are still breastfeeding at 3 months, despite having low milk productions. So what am I going to do, and what are my group going to continue to do? We're determined to determine the impact of maternal conditions on milk production, and by discovering the mechanisms involved, this will help all of us develop much more innovative and successful interventions. And by doing this, I think what we're going to do is aim for personalised support that takes into account the risk of low supply, as I mentioned, setting expectations, aiming to extend any breastfeeding, in other words, supporting the mother to continue rather than give up, and preserving and enhancing her well-being along the way. What will you do? Will you identify women antenatally or postnatally that might encounter breastfeeding difficulties? Will you think about conversations in pregnancy before the mothers run into these roadblocks or are unable to recognise them after birth, so that you can have conversations about what they might encounter and have the opportunity to educate them? And will you tailor the support that perhaps you suggest for continued breastfeeding based on the mother's situation? Then together, I would hope that we start to raise the rates of any breastfeeding. And I think that we have a lot of opportunity to do that, and as a consequence, raise the rates of exclusive breastfeeding as well. So thank you very much for your attention, and I think we are moving towards questions now.
Yes, thank you, Professor Geddes, for that presentation. That was amazing. We do have a few questions. We have about 10 minutes, so if you do have any questions, feel free to submit those via the questions panel. We'll try to get to those. The first question is hypothyroidism a concern if treated and lab values in normal range?
I don't think so. My clinicians report to me, despite the pathways that I talked about there that could impact prolactin and STAT3, what they find is if it's well controlled and the mothers are medicated, it tends not to be a problem. And that kind of makes sense with the thyroid hormones actually being involved in breast development. So I think we initially thought it might be more of a problem than it actually is, but I also would add that we haven't looked at combinations of risk factors as well. So we need some more numbers to see if that combined with other factors might be affecting the milk production.
Okay, thank you. The next question is, what do you review at the antenatal lactation consult? Do you encourage them to start antenatal hand expression at 37 weeks? Professor Geddes, your battery is showing low on the screen and we can't hear you. So if you're able to plug it in before you answer that question.
She has to see the notification as well. Hopefully she's grabbing a cord.
Yes, we will give her a few moments. We apologize for the technical difficulties here. It appears she may be finding a cord because she looks like she may have shut her video off. Can give it another minute. Thank you everyone for being patient. Okay, well, I do see some other questions that came in through the chat, the questions panel. If Professor Geddes does not rejoin us, I will have her answer them and I will send these answers for these questions out to everyone probably early next week. As we're wrapping it up, I just want to thank everyone again for joining us today for this webinar. And registration is now open for our May 17th and June 21st webinars. You can visit medilaeducation.com and get registered for those. And once we end this webinar today, an evaluation will pop up in a separate window. So if you can please fill that out and let us know what your thoughts were on this webinar. We would appreciate that. And it doesn't look like Professor Geddes is able to join us back. So as I said, I do see questions that are in the questions panel. I will make sure I get those to her and get the responses to those questions to everyone next week sometime. Again, thank you everyone for joining us today and have a great afternoon.